Well, hi everyone. I'm the director for our New Zealand registered not for profit called Common Knowledge, and I put all of the work that I and hundreds of families did, all the birth skills that we developed in the early 1970s, into a not for profit in the mid 1980s. And I've been doing a You in Childbirth series, and I'm going to continue on that today. And I'm going to talk to you about midwives. So I've been involved in the childbirth conversation since the early 1970s, when these birthing better skills developed in the 1970s. Midwives were illegal in the United States, in all 50 states, as from about the end of the 1950s. And so women were basically being forced to go into the hospital. General practice doctors really weren't doing births. It was now a specialty called obstetrics. So when I gave birth in 1970, that's just what we did. At the same time, the very first ever childbirth preparation classes were being taught in the US pretty much out of every single hospital, and that was the Lamaze method. Bradley was taught also, but privately. And so from the 60s to the 70s, multiple millions of families like myself and my husband learned birth skills because we had no choices. So the first ever childbirth preparation classes taught in the United States were entirely skills-based. You won't find that today. So there were no midwives, but there were people doing home births, certainly in the United States. But what about the rest of the world? In the rest of the world, in fact, midwives had always been integrated into modern medicine. That was just the reality. And home births were integrated into modern maternity systems throughout the world, with the exception of the United States and perhaps Canada. I'm not so familiar. I'm familiar with New Zealand history and the US history, and having talked around the world for many years, that midwives were just part of the system. They weren't continuity of care. They weren't in a partnership with you, but they were not the labor and delivery nurses that we experienced in the United States. So when people talk about midwives, they need to understand that if they live in the United States and feel that it's difficult to get a midwife, that's atypical for the rest of the world. The rest of the world, most women are seeing a midwife. They're just not seeing a continuity of care midwife as we have in New Zealand. So 98% of people in New Zealand who are pregnant have their own midwife. So when the conversation around midwifery started in the 70s and the 80s, it was really, in a very large sense, in opposition in the United States to modern medical profession. And this is what I've experienced in 50 years. This idea that there is this really oppositional approach to childbirth, obstetricians versus midwives, home versus hospital, natural versus medical. And what's curious to me, and what was curious to me in the 1970s, was when the beginning birth advocates started, it was really country to country. So in the 70s, it was not a global conversation. By the 80s, the childbirth conversation became global. And there was a decision or a conversation about, let's emulate the Dutch system, for example. And so people started to think about that. Now people would like to emulate the New Zealand system. So let's think about that. So before we get into my lifetime of 50 years with this conversation, let's take a look at our historic humanity around the world. Were there midwives? That's going to be a question. The word midwife means to be with women. So obviously there were people with women when they gave birth in many cultures. In other cultures, no, there weren't. Right? So in other cultures, women were expected to go off by themselves and have their baby. In other cultures, family members took the woman into a seclusion area. We all know about menstrual huts. There were birth huts in cultures in which The women in the woman's family went off at a certain point in pregnancy and came back at a certain point after the baby was born. In other cultures, anybody who was at the birth helped. Didn't matter whether it was a woman or a man or whoever. So you need to understand that the concept of midwife as a professional is an incredibly new concept. So there are women, just as there are potters or there are musicians, there are women and men in other cultures that are known to attend births. In India, for example, they were called dais, D-A-I. Now, were midwives respected? Many of us heard midwives were burned as witches. Well, that was only at a certain point in a certain culture and was not true globally worldwide. The dais in India were from the untouchable caste because they could handle bodily fluids. So the families prepared the woman, and then the dai, the midwife, the untouchable, came in, did the birth, did the placenta delivery, cleaned up, so she was not necessarily well respected. So we need to understand that when we hear stories about midwives were the second oldest profession, no, they aren't, right? They just are culture to culture, and that's what you need to understand. But in the 70s, in the 60s and the 70s and the 80s, because the maternity system became modern science rather than traditional birth attendants, modern people were either trained as a midwife after nursing or they were direct entry trained, which meant they were trained as a specialist to do births. That occurs. In New Zealand, they're a specialist to do births. And they were adamant that midwives, that the real midwife hadn't been trained in the medical profession. So now I want to talk to you about the politics of what happened around midwifery. There was a belief that midwives, rather than obstetricians, were the true birth providers. Well, given that in some cultures women went off by themselves, in other cultures whoever was there, in other cultures women went off with family members, that's giving misinformation. Okay, and we never really understood what the word natural meant. So we know that pregnancy and childbirth, are normal, natural, physiological life events. We know that. What does the word normal mean? What does the word natural mean? What does the word physiological mean? So in my lifetime, those three words, when taken or interpreted by people who are advocates of the natural birth movement, believe that normal, natural, and physiological means good, easy, manageable, and good outcome. And without a doubt, the modern medical maternity system treats those same words differently and says there may be a problem, it's normal and natural that there can be. Those risks can become problems. We want to solve those problems before they become tragedy. So we know that physiologically women can bleed to death. So we know that. So we know that it's natural that a baby, that if there's a twin, that the heads may be locked. Rare, but it's natural. And in fact, it's normal. So in reality, when we're having a conversation around childbirth, we have to not bend words to fit what our beliefs are. Pregnancy and childbirth are normal, natural, and physiological life events. And anything that might happen can happen. Midwives are perceived of in modern countries as though as the providers who work with low-risk women with the assumption that a low-risk woman will have a low-risk birth. So for example, if I were pregnant and I had no health issues at all, and my baby was breech, I would not then be considered low risk because my baby was breech. I'd be low risk, but my baby would be in a riskier category. So traditional, when there were people, whether it's a family, whether it's a woman going off by herself, whether it's a person who came, there was no distinction. Whatever happened at birth was dealt with. There wasn't a choice. There wasn't a modern medical system to go to. And if there was a problem, often people went to spiritual practitioners. So in the modern world, prior to modern medicine, if you lived where there were people who came to birth, they dealt with anything. Low risk, high risk, unknown risk, risks, problems, trying to resolve those problems, and tragedies. Modern midwives, if they're seen of as attending low-risk women, it is hard to sometimes identify whether that low-risk woman in pregnancy will have a low-risk birth. And there are always two elements of birth that we have to deal with. And this is talking about us. So we have to deal with suffering, which has nothing to do with risks. We've all heard that women suffered in childbirth. Why do they suffer in childbirth? Because historically throughout the world, there has not been a perception or a set of skills that women can use to handle, cope, deal with, work through, stay on top of, feel in control of the natural occurring, often intense pain of labor contractions. Because there's no way to know what your birth's going to be like. In 1970, when I gave birth, there was only a 4.5% cesarean rate, no midwives. 95% of us labored, which meant some of us labored for hours. I was quick. Some labored for days. Some of us brought risks in and we spit our kids out and coped well. Others of us were very, very healthy. And we had long drawn-out labors that lasted for days, and we suffered, but we didn't have a risk. Others had identified risks that didn't become problems. Some became problems and got sorted out. Very, very, very few became tragedies, and there were many other risks that weren't identified. So when I gave birth in 1970, it was normal and natural and physiological for risks to exist, and for us to labor and have a vaginal birth because cesareans were so risky, right? So we have to understand. So where did midwives fit into this? Well, Vietnam paramedics did a lot of births, obstetricians did, labor and delivery nurses did, and lay midwives did in the United States and probably in Canada. The rest of the world, midwives, 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 and home births. So when the conversation became global, it became global under the World Health Organization. So the World Health Organization has a thing. What's normal for cesarean rates? So in 1970, it was 3%, right? Then in the 80s, it went up to 9%. And you're thinking, how did that happen, right? And how that happened is where you sort of, there's part of you going, let's tear our hair out about this. First of all, those skills-based approach, Lamaze and Bradley, which was targeting low-risk women to learn skills to have a natural birth, pain-free labor without medical care, not enough women achieved that, low-risk women. So the next group of birth advocates went, see, skills don't work to achieve that. Women just need choice. So they wanted women to say no to more medical care, whereas if you give women choice, many of them will say yes to more medical care. And this becomes very complex. So in the 80s, WHO said 9%. What was the reason? Because women in South America were choosing to have cesareans because they didn't want to damage themselves down there and get torn. So when we started in the 70s and fathers and mothers developed all the skills in birthing better, many of the families were going to have a home birth and many of them were going to the hospital. We didn't pay any attention. Many, we didn't pay any attention. We just wanted skills. The families that developed birthing better, we wanted skills for our baby's birth. We wanted to know how to work together because dads were just coming in. Women wanted help not to suffer, and we wanted skills. So we developed skills, right? And then we also wanted midwives. They existed everywhere else, but in the United States, they wanted midwives. And when we started to think about midwifery globally, we were looking at the World Health Organization to define midwifery in a modern context and in a traditional context. So WHO, when I worked in Zimbabwe, had a program there for TBAs, traditional birth attendants. They taught them nothing about birth, nothing about birth. They just assumed that they were going to go to birth. And when you ask traditional midwives, how did you learn about birth? They would say, someone just asked me to come and I was at a birth. When you ask them, how many births a year are you attending? The answer is between 1 and 7. And they just happen to do it. Very few of them are apprenticing. They just stumble into a birth somehow, family member, friend member. WHO and the TBA program were using midwives as primary care educators. They wanted to talk about AIDS, family spacing. They wanted to take risks and put them in clinics. So you could be in a village and WHO TBA program would say, if this woman has these risks in pregnancy, refer to the clinic. That clinic might be 160 kilometers away from a hospital with no way to get there. So they would have risks in pregnancy and risks in births. But when you ask traditional birth attendants, what are the risks? There are 2. Worldwide, only 2, right? One is a woman who bleeds too much. That freaks everybody out. Everybody gets freaked. And the other is that the baby can't get out. Why are these risks? Well, obviously, if the baby can't get out, then the baby eventually dies and the mother will die. Okay? And why are they concerned about bleeding? They don't want a woman to die. Traditional, before the modern world, before birth control, this is important, we did not have a way as women to control our reproductive rights. So we lost babies. But that's not where we lost them. We lost them prior to immunizations and antibiotics. Because 20 to 30% of children around the world, until they started to immunize them, 20 to 30% died before the age of 5. That's why the population was where it was, and why the population now has grown, not because we're having more children, but our fewer children are surviving, right? So when we think about midwives and we think about traditional midwives, if you go into traditional communities, people don't know you have a cervix. Where would they know that, right? So they're doing the best they can within their cultural traditional health system. And every traditional health system for a midwife or a traditional birth attendant, every traditional health system is loaded in pregnancy and loaded in a newborn period with do's and don'ts. Don't sit in the doorway. It will obstruct your labor. Right? Don't eat this. You can have sex. No, you can't. You can work. No, you cannot. Do this, do this, do that, do that. Newborn, do this, do that, do this, do that. But when I go around the world in traditional communities with the Birthing Better skills, and I say to women in traditional communities who have lived together forever, how'd your mother teach you to just breathe in birth? People will come up with 8 responses. But if you say, how do you make your roti or chapati? All of the women in that village will have the exact same 11 skill steps. So knowing how to birth is something that's very new to our humanity, which brings me to what I want to talk about, and that is our role as pregnant families when we choose midwives. So we have, since the 70s, put midwives up on a pedestal. We even say, well, they have a calling. Well, they may, or it may just be a job or an occupation, right? They may be direct entry trained. Every direct entry midwife around the world is trained within the modern maternity system. They may not like to hear that, but they are. So we have to understand direct entry midwives may not be trained as nurses, but they are trained to evaluate risks and do tests and do assessments and monitoring and some procedures within the modern maternity system of that country. What the evidence-based practices, the guidelines to practice, the standards of care. And they have to follow those if they're professionally licensed, right? Because that indicates to consumers that they're, being professional. So the ideal in the 1980s that came up was that midwives would give women continuity of care and there would be a partnership. And this is where it gets really tricky, okay? That midwife, that woman or man who's attending you and who's going to give you continuity of care, they have other clients because this is a job. They may love their job and they may get paid by the government like they do in New Zealand and other places, or they may get privately paid. But if you're going to make a living attending births, you have to take on X number of clients a year. And that usually runs between 20 and 60 a year. That's a lot of people you're giving continuity care to. In New Zealand, when New Zealand midwives wanted to have their autonomous practice, they didn't want to be nurses, so they put up a proposal saying nurses attend people on shift 8 hours. So we, as midwives who believe that pregnancy and childbirth are normal life events that rarely require medical care, we're going to give women 24/7 care, which doesn't make sense. If pregnancy and childbirth are normal life events that rarely require medical care, why do women need 24/7 care? Now, women everywhere, I have asked tens and thousands of women around the world, would you like the same provider in pregnancy and birth? Everybody says yes. They'd all love that. They don't really care. I mean, they'd like some checkups after the birth, but really what they want is somebody to cook and clean, take care of the other kids, tidy up, do the shopping, do the laundry. That's really what they want after the birth. And that's why postnatal doulas, I mean, they have a whole world of opportunities to give people 6 months to 3 months, 6 weeks to 3 months postnatal care and do those things. Honestly, you serve the family if you can take the load off of them, right? So there's a confusion about what continuity of care is. Continuity of care can mean I attend you in pregnancy, I attend you to birth, see you a wee bit after the birth, but I attend you in conventional ways. I see you once a month and then every 2 weeks, just like a doctor does, then every week, and I come to your birth at a certain point. The Dutch midwives say, you want your labor well established, and the Dutch midwife just goes and does the delivery, and the placenta makes everything's fine, and then leave. They have people that go in and sit at the birth, but in other countries, in New Zealand, as soon as a woman wants a midwife, the midwife is expected to go because continuity of care means 24/7 care. How are they feeling? Okay. So there was also a discussion back then about midwives who worked within the maternity system that were identified as midwives, honestly. And the real midwife was the midwife who was doing home births. That was the real midwife. The midwife who was with women all the time, not just at her birth, but she was the emotional support. She was the psychological support. She was the counselor, as though this is what always happened traditionally around the world. That was a myth. That wasn't accurate in the least, anywhere. We have wound ourselves up into an illusion about what a midwife is. And that means we as women have surrendered ourselves to this perception of a midwife. And we have not been taught within our societies what our role is around childbirth. It started in the US when I gave birth, when the very first childbirth preparation classes were entirely skills based. There was a huge societal expectation that all of us attend those classes, and we did. We went for 6 weeks, 3 hours at a time. We went and we did our homework of puff breathing, hold just that, ragdoll relax, timing contractions, but we did that. That was the first ever childbirth classes, and they were all skills. Now, something remarkable happened. I lived through it, so I know, right? Multiple millions of expectant families, like my own, went into the hospital because 95% of us labored because cesareans were such major abdominal surgery, and labor and delivery nurses and obstetricians saw multiple millions of us for a 25-year period not suffer as much. The skills helped us cope. They helped us manage, help us deal with. They weren't great skills. It was the beginning, but they were something. And our husbands were there helping us do this. So my generation of people feel proud and empowered because we use some sort of skills to work through this activity we did with our baby. I, as a pregnant woman, am the only one doing this activity. Sorry, it's me doing it. It's you as a pregnant woman. We're the only ones doing it. So, in the philosophy of things, the idea was that pregnancy and childbirth are normal, natural, physiological things that just happen to women, and we just know how to do it. This has been nuts from the beginning, and I want to explain why. Being horny is normal, natural, and physiological. Being hungry is normal, natural, and physiological. All three of them are big drivers in life, aren't they? How often do we have sex? More frequently than we give birth, usually. How often do we eat? More frequently, usually, than we have sex or give birth. In fact, birth is very infrequent now that we have birth control and legal and safe abortions, no matter what your belief is about them, okay? Because we have that and we have fewer children, that one-off experience, it cannot be replayed. That is infrequent. That is life transforming. That is a big activity that we have to do, no longer has skills attached to it. Because that first skills-based method, Lamaze and Bradley, was geared towards achieving a goal, which was low-risk women achieving a natural birth, easy, manageable, pain-free, with no medical care around it, which left out the rest of us. But we went in, all of us went in, and we used those skills, and we did not suffer as much. My generation feels mostly empowered by our births. When I gave birth last in the 1980s, the whole childbirth trend had shifted because the new global advocates were saying, cows and cats aren't taught to birth. Women don't need to learn skills. They just know how to birth. Michelle O'Donnell, women should be left alone to discover birth. Carolyn Flint, a midwife. Midwives should sit in the corner and knit, right? Fathers shouldn't coach and tell women what to do. They should just support women's choices and protect the sacred space of labor. Women need to feel safe to labor, totally ignoring the fact that women birth in wars and in tsunamis, right? That they come out of poverty and abusive situations and have addictions in their home. Ignore that. Modern women need to be safe because of these hormones. This has confused the conversation. It has confused the conversation, and it's removed any responsibility from us. Our job is now just to do the research, use a skill to do the research of pros and cons around what we want at birth, make a birth plan, tell our midwife or our obstetrician what we want and don't want, and expect them to give it to us. So in the early 70s, when fathers and mothers and I developed the Birthing Better skills, we developed skills for ourselves. We wanted to do something for ourselves. We wanted to feel skilled together to work through this activity of birthing our baby. We, as women, wanted to feel more in control. The Lamaze and Bradley skills did not adjust well. They weren't often sustainable, and they weren't adaptable. Of course, many people use those skills and found them remarkable, but we need to develop skills that were for everyone, that could be used for everyone. And so Birthing Better Families, for a 10-year period from the 70s to the 80s, developed skills to cope, manage, work through, stay on top of, feel in control of labor, because we were all laboring. What happened in the 80s? Remarkable changes. Birth control, remarkable change, absolutely remarkable change. Fashion, my generation started to wear bikinis. So we said to the medical profession, we don't want to be left with an ugly scar if we have a cesarean. So they came up with a bikini cut. They didn't come up with it on their own. They got pressured by us. We wanted our husbands in with us if we had a cesarean. So they came up with the epidural and the spinal. Right? So the medical profession has responded to us. And in the United States, people who have advocated for midwifery have worked their butts off to get midwives recognized in the United States. And some states have done that, either as a nurse midwife or a direct entry midwife. New Zealand, in the 1990, midwives took over maternity care, 98% of people. They put in place what everybody wanted, and it is not a functional system because our responsibility as pregnant families was reduced to just telling midwives what we want. And we expect them to give it to us in a 24/7 continuity of care partnership in which pregnancy and childbirth are considered to be normal life events that rarely require medical care, but midwives in New Zealand go to school for 4 years, right? So if they go to school for 4 years, this is a very weak partnership. And so when you're thinking of having a midwife, this is what I want you to know. You have a responsibility to become skilled. Now, in the 1980s, when cesareans started to rise, Birthing Better Families, and this was not a group of people that got together, it was just sort of by accident, but we shifted our focus because we knew we would have more medical care if, when we had a normal, natural, physiological birth where there was no cesareans available, some of us could labor for days, right? And that put our baby and ourselves at risk because remember what traditional women don't want? They don't want babies not to be able to get out. And when a woman labors for days, there is that sense that this is going to be a problem, right? So we didn't want that. So Birthing Better Families focused on preparing our body, how to create space. And men were the drivers in this because they see birth from the outside. They know and hear. They see and hear whether a woman's coping well or not. And they can see it and hear it instantaneously. And they figured it out. Look, pregnancy is about growing a big object inside a woman's body. At some point, that big object has to come out. It's a container. Is there any way we can manipulate the container to get it more open, more flexible, more soft, more able to open up to let this big object out? And the answer was yes, of course we could. But we didn't know beforehand, right? We do now. Birthing Better skills, we do now. So if you have an interest in Birthing Better, it's birthingbetter.org. Go to it. We're launching a new website soon. We have 12 courses. Everything's modules. But you want to prepare your body for birth, starting at 24 weeks. So this is the concept that Birthing Better Families developed, okay? This is the concept that we want you to pass on. It is normal and natural when you're pregnant to self-learn birth and birth coaching skills. We don't care if it's Birthing Better. Learn Lamaze, learn Bradley, learn hypnobirthing, learn calm birth, learn birthing within. Whatever, learn skills from 24 weeks and then use the skills when you work through the activity of birthing your baby. Because it's your baby. We get pregnant to have a baby, not a type of birth. And it's an activity, like having sex and being horny. So how many of us raise our hands for learning skills to be a good lover? Yes, we do. How many of us, when we instinctively are hungry, instinctively want to eat something, how many of us as parents have spent months taking things out of children's mouths that are not appropriate to put in there? Babies do not have an instinctive ability, nor do we, to recognize what is safe and not safe to eat. Even if we know what it is, we put food that has bacteria in our and get sick from it. So much less going to another country, seen a little red berry on a tree. We don't know if that's safe or not. We have to learn. Those are called skills, right? The next thing we have to be skilled about is to learn how to cook, right? So when you hear people say, well, childbirth is natural, normal, and physiological, women just know how to do it, this is not accurate, and it adds confusion. 100% of pregnant women will give birth, followed by one way or another, right? They will either suffer or not. They will either have a good outcome or not. So we need to understand that when we become skilled, we put skills in our basket that makes us more competent to do this activity of birthing our babies. When we do that and we have a midwife, right? Because this is about midwives, we support them. This is so important. If we want midwives supported, if we want them giving us continuity of care, we need to meet them in a partnership. That means they are skilled to safeguard the health and well-being of our baby, and we need to be skilled to prepare our body and to work through this activity of birthing our baby. It's as simple as that. We have to become skilled. We have to now spread this concept. It's just normal and natural when you're pregnant to self-learn birth and birth coaching skills and use them to birth your baby. And you want to tell your midwife what skill methods you're using. And if you look like you're coping and managing well and your partner's helping you, you tell her, praise us. We need to hear that this pleases you, that we cared enough about our relationship with you to become effectively skilled to work through the activity of birthing our baby. And if we look a bit overwhelmed, go back to our notes, see what skills we learned, and encourage us to use them. Because we know, after 50 years of working with families, that when we give the message to people, midwives know. They're the true providers at birth. Trust your midwife. Birth is normal. We know that this is adding to the confusion in childbirth and adding to the discouragement of midwives. So let me tell you about New Zealand, the midwifery profession. Love it. Absolutely wonderful. They just missed out the part of families being skilled to lift up the partnership. And they're very resistant to it because they just believe pregnancy and childbirth are normal life events. They just think women know how to do it. So they've missed that, even with our trust saying to them, no, we can help you grow this skilled birthing population. They're still not there. But in 1990, the cesarean rate was 12.9%. They believed they could bring it down. They believed they could have more home births. They could believe that more women would have natural births, which meant natural births without medical care. And the cesarean rate in New Zealand is over 26% now. So, and it's not the midwife's failure. It is not the midwife's failure. It is the failure in the childbirth conversation that when skills existed and choice came along, that those were not married. So it should have sounded like this in the 70s. Skills, learn them. Other skills-based methods would have evolved as they have. Learn skills, you got to do the activity. Here you can have choices, and you hope that you have choices available. You might lack them, in which case skills are great. Your choices might change, so skills are great. Your choices might unfold the way you want them to. Skills are great. That could have happened, and that didn't happen. Skills were pushed aside. Choices were elevated. We're 40 years down there, and women who are choosing natural birth, not enough of them are achieving it, and women are demeaned for choosing to have non-laboring cesareans. It's your baby's birth. Use skills. Learn skills in pregnancy, and if you can have a non-laboring cesarean, use them on the way to the hospital. That's your labor. Use them while being prepped. That's your transition. Use them during the surgery. Work through your baby's birth journey using skills together. It empowers you. It keeps you present, keeps you focused, it keeps you engaged. Regardless of what's happening to or around you, you don't lose it. You don't feel surreal. You don't have trouble recovering from the birth. You get on with parenting. So how best can you support your midwives? And tell your midwives, Common Knowledge Trust is telling you this, and tell them they can work with us to learn how to tell their clients. So can the doulas, so can the childbirth educators, so can you as an obstetrician. We want all birth providers now to tell their clients it's normal and natural when you're pregnant to learn some skills and then use them during your baby's birth. Here's a handout of all the skills-based methods we know. Pick one or more. From 24 weeks, we'll mark in your note, just like your choices, what skills you're learning, and then be able to refer to them, and anybody can, and help everybody have a more skilled birthing population. We need to keep midwives. And the best way that we can keep midwives, particularly continuity care ones, who are caring enough to give us a lot of attention, is that if we meet them as skilled partners for our task is to birth effectively. We want to birth effectively. Because if we're having a home birth, we don't want to go to the hospital. We don't want a problem to exist in a home birth. If we're having certain risks, like breaches and twins, we want to prepare our body. Because what is the medical profession all about? They sit at our crotch. They use forceps and they use episiotomies because they saw how tight women were. Oh my God. I mean, honestly, right? Why did we lie on our back? Because our pelvis was open. But then everybody wanted us to sit back in a semi-recumbent position, which closes our sacrum, makes it harder for a baby to come out. So there is so much in the confusion of childbirth. But if we want a vibrant midwifery model, we have to become a skilled birthing population. And I've gone over my 40 minutes, so I've got to stop. Yep. So I will continue this series. We are on YouTube. It's Birthing Better. I think it's Birthing Better 1. Don't know. We only have a few subscribers, 200 and something. Please subscribe, like this, share it, and comment. Help us help midwives by growing a self-learning, skilled birthing population. Thank you very much for listening, and see you again. Bye-bye.